Good morning, Eric and Joseph. Good morning, ladies and gentlemen, my dear colleagues. While I'm going from the Franco-British Institute, maybe we should say the Franco-Brexiter Institute, I don't know, to discuss adjuvant therapy in colorectal cancer. I propose to divide this presentation in 5 parts, looking first briefly at our achievements, then at what is ongoing, followed by biomarkers, the way to improve our therapies, and then improve our clinical research. So briefly, our achievements. In chemotherapy, we have in the adjuvant setting fluoropyrimidine with or without oxaliplatin. Leucovorin and 5-FU has proven some efficacy in stage 2 in the patient with microsatellite stable tumors and in stage 3. Capecitabine has proved efficacy in stage 3. Fluoropyrimidine plus oxaliplatin in high-risk stage 2, at least in DFS, and in stage 3 patients. UFT had demonstrated non-inferiority over leucovorin and 5-FU, while irinotecan plus fluoropyrimidine, raltetrexed, S1 have failed in the adjuvant setting, and TAS-102 has not been used yet. With our targeted therapies, we have no proof of efficacy in the adjuvant setting. Both cetuximab and bevacizumab failed in 2 trials. Regorafenib is ongoing in an adjuvant trial done by an ACBP, C13. It is given after chemotherapy. Panitumumab, ramucirumab, and aflibercept have not been tested in adjuvant setting. The good news is the results maintained for oxaliplatin over time. In this 10 years update of Mosaic, you'll see the patients with more than 3 lymph nodes have a huge benefit of oxaliplatin, a 15% absolute benefit in overall survival, or a 30% reduction in the risk of death. We know also that the results achieved with leucovorin and 5-FU in stage 3 is consistent over time, but with oxaliplatin we have these changes. It seems like our regimens are improving in stage 3. This is, I believe, a Will Rogers effect, or the effect of stage migration, when more lymph nodes are now examined than in the older trials. But it's an important finding. You see, for example, in the FOX4 regimen that was used in the Mosaic trial was also the control arm of the AVANT trial. In stage 3, between the 2 studies at 8 years difference, the benefit in 3-year disease-free survival is 3% in the AVANT trial. In 5-year OS, it's 9%. In 3 years DFS in patients with less than 4 lymph nodes, it's 13%, and those with more than 4 lymph nodes is 10%. The results that we will expect in any adjuvant trials are observed just with a better staging. We learned from the Accent meta-analysis that elderly patients do not benefit of oxaliplatin. However, it might not be the truth for all elderly patients. For example, the gender effects need still to be revisited. Here, in terms of DFS, DFS is recurrence and death of other causes than cancer. There is obviously no benefit in elderly male patients over 70 years of age, but there is a benefit in female patients over 70 years of age. So this is also important to consider for the future of adjuvant therapy. We learned from the metastatic colorectal cancer that sinus is an important prognostic factor. Patients with left colon with metastatic colorectal cancer do better than patients with right colon, and especially patients who receive cetuximab. There is a huge difference. It's 19.3 months difference in median survival between right and left colon. However, it's not exactly the same in the adjuvant setting. Here, based on the SEER database, you see that only in stage 3 you have a better prognosis in patients with stage 3. This is also observed in the MOSAIC trial, where the patient with the left colon, stage 3, have a small advantage over the patient with the right colon. But it's obviously the opposite in patients who have a stage 2, where the right colon is doing better than the left colon. And this is probably due to the increase in patients with MSI in the right colon. Survival after relapse is the main reason why there is a difference between left and right colon, even in the adjuvant trials. But here, in the MOSAIC trial, it's not so obvious in the patients who were exposed to fluoropyrimidine alone, while the difference appears in the patient who received FOLFOX4. Probably in one arm, they still have, at relapse, more active regimens, and this might explain these differences according to the regimen. So now, how to improve our adjuvant treatment? Look at what is ongoing. Clinicaltrials.gov, I look at adjuvant colon cancer and could find up to 250 studies. So limiting to ongoing studies, 99, and further limiting to adjuvant colon and unpublished, updated or ongoing, it remains 43 ongoing studies. 17 of these studies are dealing with therapy. IDEA or IDEA-like trial in 3 cases. IDEA, I will expose that at the next slide. Aspirin, 5 trials looking at aspirin. Regorafenib, 2 trials. Liver or peritoneal route of administration, 3 trials. Maintenance, 1. A comparison of FOLFIRI and FOLFOX in the adjuvant setting, 1 study. 1 for elderly patients, and the last one, traditional medicine, coming from China. Other adjuvant trials look at the strategy, neoadjuvant therapy, some kind of immunology, but not with the checkpoint inhibitors, to support the look at the pathology, biomarkers, and physical activity. It's a pity to see that I cannot feel that a big success can come from these studies. It's also a pity to see that some studies like IDEA are done outside the IDEA meta-analysis. It's a pity to see that 5 studies are looking at aspirin. So clearly, this should be worldwide studies, or the database should be joined, like in IDEA. So IDEA, meta-analysis, is done based on 6 trials. 3 performed in Europe, in Italy, Tosca, in France, GERCOR, and in Greece, ORG. 1 done in UK, the Scott trial, 1 in US, and 1 in Japan. So this trial is devoted to see if we can limit the duration of adjuvant therapy, comparing 3 months to 6 months chemotherapy in patients with stage 2, but mainly stage 3. This is a non-inferiority trial, and the hypotheses were done to have a non-inferiority at a level of 1.12 hazard ratio. 10,500 patients were needed, and we have already more than 12,000 patients in this database, and results are expected at the end of the year or early next year. So this is a very nice and beautiful example of international collaboration. I would like to say a few words about the challenge trial. The challenge trial is looking at physical activity. There was a feasibility report at ASCO this year when the inclusion were just a little over 400. So this is some kind of difficult trial because it was initiated in 2008 and it has just reached half of the inclusion that were scheduled. One other important thing to look at is aspirin, but not in all patients, in patients with mutant PI3 kinase, based on this report published in the New England 4 years ago, that the patient with mutated PI3 kinase do very well with aspirin. And this is the base of the ASPIC trial led by David Kerr, which will compare aspirin to placebo in this subgroup of patients, not very frequent. I would like also to discuss briefly neoadjuvant therapy. Neoadjuvant therapy is done in this FOLFOX-TROT study In the FOLFOX study, there are minor sub-studies looking at the effect of panitumumab and also the duration of treatment, but they mainly compare adjuvant to neoadjuvant. And they have published 4 years ago an interim analysis looking at the staging in the patient who have adjuvant therapy. They were randomized before surgery, so you have the assessment of radiological staging. And obviously, we learned that the radiological staging is really inaccurate, with 50% of the radiological T4 being PT3, and 44% of the N plus were in fact PN0. But we learned also from this trial that the patients receive their chemotherapy 13 days after randomization. It's 61 days when they are in the adjuvant group. So while an early chemotherapy benefit to the patient will be an important question here. Another neoadjuvant trial is the PEPITA-2 trial done in Belgium by Alain Leeds. Here they are looking at PET response. That means that the patient had a baseline PET scan, a cycle of FOLFOX, and after this first cycle, they are assessed for metabolic response. Then if they are stage 2 after surgery, they are treated at physician discretion. And if they are stage 3, they receive adjuvant chemotherapy. So the hypothesis of this trial is to have 50% PET responders, 60% stage 3, and have a three-year disease-free survival of 15% in non-responders versus 83% in responders. It might be a little bit ambitious in the control arm due to the Wild Rogers effect that we have observed before, but it's interesting to see if we have here a new biomarker. And now among the biomarkers, maybe the most known biomarker is MSI. MSI occur in approximately 10% of the patients. 3/4 are the sporadic MSI, where the driver is MLHR1 hypermethylation, and you know that these patients frequently harbor a BRAF mutation. And the opposite, the Lynch syndrome or Lynch-like syndrome, are approximately 1/4 of these patients. And here it's germline mutations on the MMR genes, and these patients frequently harbor a KRAS mutation. We know from recent studies that the prognosis of sporadic MSI patients is worse than the Lynch syndrome, at least in terms of overall survival. We know for a while that patients with MSI stage 2 have a detrimental effect of fluoropyrimidine in this study done by Dan Sargent, while the stage 3 have a limited benefit of fluoropyrimidine. With oxaliplatin, at least in stage 3, there is a benefit, a wider benefit of chemotherapy, oxaliplatin-based chemotherapy. We know also from recent studies published in the JAMA Oncology that the mutation BRAF and KRAS have a poor prognosis value in the patient with microsatellite stable tumor, while it is the opposite in MSI patient, where the mutation have a better prognosis, or at least a trend for a better prognosis. We know also that oxaliplatin is active in BRAF mutant tumor in the adjuvant setting, either microsatellite stable or microsatellite unstable. Among biomarkers, we have the recurrence score, which is a gene signature that can determine 3 levels of risk in the patient with colorectal cancer. But this is not enough, I believe, to recognize what is important with the biomarkers. It means that the patients stage 2 who should be treated and the patient with stage 3 who should not be treated or treated with oxaliplatin. The coloprint is another gene signature able to recognize some patients with high risk. Approximately 40% have recognized at high risk with the coloprint. We have also the glycylcyclase 2 expression in lymph nodes. if this marker is positive, these patients have a prognosis similar to those who have positive lymph nodes. Guanylyl cyclase, I'm sorry. Immunoscore is another potential biomarker looking at the presence of the T cells inside the tumor or in the margin of the tumor, and able to identify a subgroup of patients with high risk. So these patients should have a different treatment than the other patients. And CDX2, it has another biomarker recently published that's able to recognize patients with stage 2 who have a poor prognosis when they are CDX2 negative and a good prognosis when they are treated. Unfortunately, only 7% of the patients are CDX2 negative. So this is all these biomarkers are still need to have further studies to validate their prognostic value before being used in a clinical setting. We can think to use also the consensus molecular subtype that is now well known and depends on the location of the primary tumor. And this has been done in one trial, the CO7 trial by an SABP. And just only the patients with CMS4 were found to have a worse prognosis than the others. CMS4 are the patients who have the mesenchymal features. They could not find any predictive marker inside the CMS for the efficacy of therapy, even if they expected to see a benefit in the enterocyte subtypes that crossover with the MSI subtype, immune subtype of the CMS. But unfortunately, if it was the case in the discovery cohort, it was not in the validation cohort. So now that we have seen the way to better understand our disease, how can we improve the adjuvant treatment of colon cancer? We can do like Joseph Tabernereau suggested, to look at the molecular subtypes to define the best therapies. It is certainly true for the CMS1, the immune patients, where we know in the advanced disease that the immune checkpoints are doing dramatic improvement in survival. But here it's just to say that this is just the beginning. There are a lot of molecules, immunomodulating molecules that can be targeted and to improve what we already have with this immunotherapy. We must not forget that chemotherapy can help the immunotherapy. Based on this is the new concept of chemoimmunotherapy, with 5-fluorouracil able to kill some tumor suppressor cells, with oxaliplatin inducing the immune cell death, presenting more antigens to the immune system, like metronomic chemotherapy. And we have all these molecules that can target either immunomodulating molecules or are known to have a positive effect with the addition of the checkpoint inhibitors, like also the vaccine. I cannot develop all that because I have only 1 minute more. Other things to target of interest are dormancy, that can be targeted with angiogenesis, and this can be done only after chemotherapy, like in the regorafenib study performed by the NSABP. And we can also think to target the stem cells, like the BBI-CO8, and this is a way to maybe eradicate the primary clone of the tumor. So, but having a lot of drugs is not enough. We have to do the clinical trials, and here we face a very big hurdle. It is the cost of an adjuvant therapy, which is more than 100 million euros. And this obviously cannot be done if we must combine new molecules at all the times. So it's why we should move from the classical development schedule. That means that we have a new drug, we look for registration in the advanced disease. If they have good sales, we think adjuvant therapy. It's not the way to do that. We should, if we have a new drug with a rationale for adjuvant, it should start from the beginning. And to maintain the cost, I propose that the academic groups with private and public fundings do this kind of trials that we urgently need to advance in the adjuvant setting. And to close, maybe we will have new algorithms in the adjuvant setting based on better staging with the use of good prognostic biomarkers to precisely define the risk of the patient, low risk, intermediate risk, high risk. We have predictive biomarkers that we already know some of them that help us to define which are the treatment to use. And in case of no predictive biomarkers, we can still think to use immunotherapy, at least in some subpopulation like the CMS4. Well, I'm sorry, I cannot develop that. Just to say that MSI are not alone to be the hypermutated tumor. We have also the DNA polymerase E that are another subgroup that should benefit also of MSI, as well as all the biomarkers that we already know. I thank you for your attention.